Hello, my name is Michael Hoffman, and I'm excited to give you this talk titled What's Next for PSMA Imaging and Theranostics at the GAP 2020 meeting. Here are some of my disclosures. I'm a nuclear medicine physician at Peter Mac in Melbourne, and PSMA PET-CT and Theranostics has become my area of research interest in the last 6 years. What is PSMA? PSMA, or prostate-specific membrane antigen, is a cell surface glycoprotein which is highly overexpressed in prostate cancer, particularly in castration-resistant or metastatic disease. We have a variety of small molecules that bind with high affinity to the extracellular domain and can be labeled with gallium-68 or fluorine-18 for PET-CT imaging. Here's patient number 1 that we imaged at Peter Mac back in June 2014, a man with a Gleason 9 prostate cancer, normal CT, MRI and bone scan, scheduled to undergo a radical prostatectomy. But the PSMA PET showed the prostate primary lighting up very brightly, but also this lymph node measuring only 3 millimeters, barely visible on the CT, and also an osseous metastasis. His management was changed to enzalutamide, a hormone therapy at the time. So the very first patient we imaged at Peter Mac having a high management impact. It's also very specific. Here's a man with a Gleason 9 prostate cancer who's thought to have metastatic disease at baseline, a sclerotic lesion seen on CT, also seen on MR and on bone scan. So the patient's prostatectomy was abandoned, but the PSMA PET showed the opposite findings. The primary tumor lighted up very brightly, but the osseous metastasis had no uptake, suggesting that this was a benign Bowley island. And indeed, this was subsequently confirmed. There's been an exponential growth in PSMA PET and theranostic research in the last 5 to 6 years. We can see this year there'll be over 700 manuscripts talking about PSMA. We recently published the first randomized trial in which we took men with newly diagnosed prostate cancer and randomized them to either a standard of care CT bone scan or a PSMA PET-CT. The results pleasingly published in The Lancet in March this year. Here was the study design. We took men with high-risk biopsy-proven prostate cancer, 300 men, 10 centres around Australia, randomised them, followed these men up for 6 months, the primary endpoint being accuracy. And what we saw was that the combined findings of both a CT and a bone scan had an accuracy of 65% compared to 92% for PSMA PET in a single study. So that's a 27% absolute greater accuracy for PET-CT with PSMA compared to conventional imaging. We had a number of other secondary endpoints such as management impact, reporter agreement, number of equivocal studies, radiation dose, all favouring PSMA PET-CT. This test also has good utility in men after prostatectomy or after receiving radiation with biochemical recurrence when PSA is rising. This is a meta-analysis we published which has over 670 citations, and we can see at various PSA levels what the PSMA PET positivity rate is. And this is a group of men where conventional imaging is not very useful. CT scan, MRI, not very useful, but we can see with a PSA over 1, more than 70% of men were able to localize where the disease is on a PSMA PET. Here's a manuscript that I did with my colleagues at UCLA and UCSF comparing PSMA PET to fluciclovine or FACBC. This is Axiom PET, which is FDA approved in the US, not very much used in Australia. And what we see here is that the overall accuracy of PSMA in this prospective 50-patient study was 56% compared to 26% for the Axiom PET. PSMA PET's also redefining a group of men that with so-called non-metastatic castration-resistant prostate cancer. These are men who have rising PSA on hormone treatment. So clearly they have recurrent disease, but conventional imaging is unremarkable, normal. And we looked at these men in a multi-center cohort with my German colleagues, and what we saw was that 98% of these men had an abnormal PSMA PET, 54% with pelvic nodal disease, 55% with metastatic disease. So PSMA PET really redefining this group of men. And this is finding its way to guidelines. This is the European Association of Urology guidelines. which now recommends to at least consider PSMA PET with biochemical recurrence. And I hope over the next short period to see the results of the pro-PSMA randomized study for staging find their way through to our clinical guidelines. Now, for the rest of the talk, we're going to shift to theranostics. So for those not familiar with this term, this is a word that encompasses a targeted therapeutic and a diagnostic companion. So we can do a neat trick. We change the gallium-68, which is a positron emitter, to lutetium-177, which is a beta emitter. This is a beta emitter, a little bit like radioactive iodine, 7-day half-life, 1 millimeter path length. It's distributed exactly the same way as we can see on the PET scan, but it delivers high energy beta particles to kill tumor cells. And with a 1 millimeter path length, there's also very limited damage to normal tissues. So we give this as an intravenous injection, and it really finds its way to the tumors wherever they are. A very clever way to deliver high doses of radiation to men with metastatic disease. We've had an interest in this area actually for a long time using lutetium dotatate for treating neuroendocrine tumors at Peter Mac. You can see the program rapidly growing since 2005. And in the last 5 years, transitioning across to treating prostate cancer, a program which has been growing very rapidly. We started with this 30-patient prospective phase 2 study, the first prospective study of lutetium PSMA anywhere in the world. And we took men with castration-resistant disease who had progressed after docetaxel, abiraterone, or enzalutamide. And so they had very limited treatment options, and we gave them lutetium PSMA. And here's a waterfall plot of the PSA responses in the 50 men. We subsequently expanded the study from 30 to 50. We see an over 50% decline, considered a favorable response by most criteria in 64% of men. And this was quite a striking result. And men had improved quality of life and minimal side effects from this treatment. This phase 2 study led onto an Australian randomized control trial, which I'll show you in the next slide. But first, an image of the year from the Society of Nuclear Medicine from this 50-patient study. We can see the PSMA PETs before and after lutetium therapy in the 8 best responders in this 50-patient study. And we can see just the degree of clarity with which we can visualize the extent of metastatic disease with the PET scan, and also the effectiveness of the lutetium PSMA. So as I alluded to, we subsequently have gone on to do a randomized study. This is a 200-patient study conducted at 11 sites around Australia, run by the ANZUP Clinical Trials Group, funded by the Prostate Cancer Foundation of Australia, together with other partners, including Endosite. And we saw that 66% of men randomized to lutetium had a PSA fall of 50% or more, compared to only 37% with carbazitaxel. So this is a very large difference between the two arms. This data presented as an oral presentation at ASCO earlier this year. It's a very well tolerated treatment, some grade 1 dry mouth, dry eyes, and grade 3 or 4 neutropenia in 11% of men. Here's an example of an exceptional responder. We see this in maybe 15% of men who have lutetium therapy. A 69-year-old man progressed after docetaxel, enzalutamide, abiraterone, carbazitaxel, no real treatment options left. 175 grade delivered to this lymph node after 1 cycle of lutetium. PSA became undetectable, and it stayed that way for 18 months, at which point the patient progressed. He's since had several further cycles of lutetium therapy and has done very well and is alive almost 5 years later, well and asymptomatic. One of the great things about this treatment is that it's really a form of precision medicine. We do PET-CT imaging to determine who is suitable for therapy. And by adding in an FDG, in addition to the PSMA PET, we can really select very carefully which men have PSMA expression at all sites of disease. We can also quantify the radiation dose using SPECT-CT imaging at multiple time points after giving the lutetium. And here we can see a whole body map with anything in red having received 50 gray or higher. And we could see that if the overall dose to tumor was less than 10 gray, there were 10 non-responders and only 1 responder. We're awaiting the results of the VISION trial, a phase 3 industry-led trial. We hope to see the results of this in the second quarter of next year. And in the meantime, we're working on how to improve this therapy more, either with combinations or by using it earlier. So we currently have 5 trials open at Peter Mac. The PRINCE trial, combining lutetium with immunotherapy, led by Associate Professor Sandhu, one of our medical oncologists, who's also leading the LUPARP trial, combining lutetium PSMA with a PARP inhibitor. We have the ENZA-P trial, randomizing men to enzalutamide versus enzalutamide plus lutetium PSMA. And then we're bringing it earlier, back to the castrate-sensitive population with the upfront PSMA PET study and also the lutectomy study. So I'll just show you a slide of 2 of these studies. The lutectomy study, we're giving 1 or 2 cycles of lutetium prior to prostatectomy to see what sort of dose we can get to the prostate gland. And in upfront PSMA, we're randomizing men to either lutetium PSMA followed by standard of care docetaxel or docetaxel, a study led by Associate Professor Arun Azad in conjunction with Movember. There's a lot of interest in this therapy around the world. I had the pleasure of attending the Advanced Prostate Cancer Consensus Conference last year in Basel, and the question was asked of an expert panel, would you recommend lutetium PSMA for patients with PSMA imaging positive disease who have exhausted approved treatments and cannot enroll in a clinical trial? And 42% said yes in the majority of patients, 46% in a minority of selected patients. So if you're thinking about starting PSMA PET imaging or PSMA Theranostics in your center, I suggest you work very closely with your uro-oncology colleagues. At Peter Mac, we work really closely with our urologists, medical oncologists, radiation oncologists, and also our laboratory scientists in this program. And I'm pleased to tell you that as a result of a large grant from the US Prostate Cancer Foundation, we're able to establish the Prostate Theranostics and Imaging Center of Excellence, PROSTIC, at Peter Mac in the middle of this year, with 3 main aims: to increase the number of clinical trials, perhaps from 5 to around 10 trials, to do discovery research in next generation PSMA ligands, and also to provide some education. If you want to keep up to date, we do have a Twitter handle for our Center of Excellence that you can follow at PROSTIC. We hold some regular webinars. This is one that we recently held, and you can watch these on our YouTube PROSTIC TV channel, and you can subscribe using the link above. And with that, I'd like to thank you all for your attention and thank all our collaborators, both at Peter Mac, but also our funding partners and collaborative partners. None of this work would be possible without the amazing team that do all this work. And with that, thank you again, and hope you enjoy the rest of the conference. Thank you so much.